Good afternoon. Our discussion this afternoon is about abnormal uterine bleeding. Vaginal bleeding is one of the most common gynecologic complaints and composes 70% of the gynecologic consults in the clinic. When you say abnormal uterine bleeding, it is always a symptom of an underlying problem, so it refers to anything that interferes with the normal endometrial cavity, its hormonal cyclicity, and hemostasis. It has an incidence of 3 to 30% in all reproductive women. When you say abnormal uterine bleeding, it encompasses any significant deviation from the normal characteristics of your menstrual bleeding. So it can either be a deviation from the frequency, the regularity, the volume, and the duration of your menstrual bleeding. It also describes all abnormal menstrual signs and symptoms arising from the uterine corpus. The, our discussion this afternoon will include the 2018 revisions of the FIGO systems of the causes of abnormal uterine bleeding. In the FIGO System 1, the frequency of your normal menses will occur every 24 to 38 days, and it has a regularity of plus or minus 2 to 20 days, and the duration is between 4 to 8 days, and the volume is between 5 to 80 ml per cycle. In the new classification, amenorrhea is now part of your AUB, and the regularity now occurs between 7 to 9 days, and the duration of your menstrual cycle should be at least 8 days. And the bleeding is now not being quantified. So as long as the volume is sufficient to interfere with the woman's quality of life, we can now label it as AUB. Metrorrhagia, which is found in your book, which is defined as menses which occur between clearly defined cyclic and predictable menses, which may occur randomly or predictably on the same day in each cycle, is now termed as intermenstrual bleeding. Menorrhagia, which is defined as excessive menstrual blood loss, which interferes with a woman's physical, emotional, social, and material quality of life, and which can occur alone or in combination with other symptoms, is now termed as heavy menstrual bleeding or HMB. Dysfunctional uterine bleeding or DUB should no longer be used because it is a basket diagnosis, and when you use it, it means that you are not aware of the local mechanisms concerning the hemostasis. So your old DUB now includes your coagulopathies, your ovulatory disorders, and endometrial dysfunction. In the FIGO system 2, the causes of AUB is being categorized into 9. So these are the PAM group and the Cohen group. The PAM refers to your polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia, and the Cohen group refers to your coagulopathy, ovulatory dysfunction, endometrial disorders, iatrogenic, and not otherwise classified. So the PAM group refers to structural entities which can either be measured visually with imaging techniques and or documented with histopathology, while the Cohen group refers to non-structural entities which is not identified by imaging or histopathology. So we will now discuss the different categories. The P in the PAM group refers to polyp. Endometrial polyps are widely recognized structural abnormalities which causes AUB. So this is found in all age groups, mostly in older women. This may present as either HMB, IMB, or postmenopausal bleeding and may be associated with dysmenorrhea. The diagnosis can be made based on either a combination of ultrasound or hysteroscopic imaging with or without histopath. On the left side, you can see the hysteroscopic image of what an endometrial polyp is. So it is a tongue-like protrusion within the endometrial cavity. On your right side is an ultrasound finding of endometrial polyp. A refers to your adenomyosis. Adenomyosis is a benign condition of the uterus caused by a proliferation of your endometrial glands and stroma, which will lead to ill-defined lesions within the endometrium causing smooth muscle hyperplasia and hypertrophy. So, this is a normal uterus. So you can see, you can actually delineate the endometrium, which is the inner lining, and the myometrium, which is the muscle of your uterus. So, with the delineation between the endometrium and your myometrium, you have a flexible muscular tissue. In adenomyosis, however, your endometrial glands, both the stroma and the glands, will be dispersed within the myometrium. So you cannot delineate clearly where is the endometrium from the myometrium. This causes rigidity of your muscular tissue. So what happens? In the diffuse type of adenomyosis, all of your uterus will be hypertrophied and will be rigid, whereas in the localized type, only a portion of the uterus becomes rigid and hypertrophied. So how can adenomyosis cause abnormal uterine bleeding? So these are the different hypotheses given. This is like AUB is secondary to an increased endometrial surface. There is an altered prostaglandin prostacyclin balance. There is hampered myometrial contractility, or there is an abnormal myometrial angiogenesis associated with fragile blood vessels. So, in the new FIGO 2 classification, the presence of two or more of these criteria according to the morphological uterosonographic assessment is highly associated with the diagnosis of adenomyosis. So, what are these? It can either be the presence of myometrial thickening, the presence of myometrial cysts, the hyperechoic islands, presence of fan-shaped shadowing, echogenic or subendometrial lines and buds, presence of transmissional vascularity, or the presence of either an irregular or interrupted junctional zones. Leiomyomas or fibroids, on the other hand, are benign tumors that arises from the overgrowth of your both smooth muscle and connective tissue in the uterus. So these are examples of your myoma. What are the types of myoma? So we have four types. The submucous type, these are the ones that are found within your uterine cavity. So these are highly vascularized with large fragile vessels on their surfaces. And bleeding during menses cannot be stopped promptly by myometrial contractions because of their intracavitary position. And when the myoma is within the muscle or in the myometrium, it is now termed as intramural, and if it is close to the outer surface, it is subserosal, and if it is independent of the uterus, it is a parasitic myoma. So this is your different types of myoma. The submucous is within the uterine cavity, the intramural is within the muscle, and the subserosal is more closer to the outer surface. The myoma usually causes heavy menstrual bleeding sufficiently enough to cause severe anemia. So how can myoma cause AUB? This may result from the increased surface of your endometrium due to mechanical distortion, or it may be secondary to the ulceration and hemorrhage of your endometrium overlying the submucous fibroids, or the interference by the myomas of the uterine hemostasis, or there is a mechanical compression of the venous drainage by the myomas at any site, or there is dilatation of the venous plexuses draining the endometrium. In the FIGO subclassification of myomas, it has been noted that as long as the myoma contacts the endometrium, it is classified as submucous. All the rest will be as others, so either intramural, subserous. So the M refers to the malignant process or the pre-malignant hyperplasia ongoing in the uterus. So let us now discuss the Cohen group. The AUB secondary to a coagulopathy refers to a spectrum of systemic disorders of hemostasis which can cause AUB. Among the disorders of hemostasis, von Willebrand's disease can cause AUB in 13% of cases followed by your IPP. And the pharmacologic agents that would impair blood coagulation is no longer part of this category. In the ovulatory dysfunction, we have two types, the ovulatory and the anovulatory type. In the ovulatory dysfunction, the menses here are often predictable, occurring every 24 to 38 days, And if an endometrial biopsy is being done at this time, a secretory change will be found. The anovulatory dysfunction, on the other hand, the menses are often irregular and heavy, and often interspersed with episodes of amenorrhea. Your ovulatory dysfunction, either ovulatory or anovulatory, most commonly occurs after menarche or just before menopause. So it may be secondary to an endocrinopathy like PCOS, your hypothyroidism, your hyperprolactinemia, mental stress, obesity, anorexia, weight loss, or extreme exercise. If your AUB secondary to endometrial dysfunction, the menstrual disturbance here is heavy and regular. So this refers to local disturbances in your endometrial function. So the cause is either an excessive or deficient proteins that have impact on the coagulation mechanism. So what is reduced are often your vasoconstrictors or your clotting mechanisms, and the vasodilators and fibrinolytic activity are often increased. So in endometrial dysfunction, your menses are often predictable and cyclic, but there is no identifiable causes, meaning there is no endocrine problem associated. And as I've said before, it may refer to deficiencies in local production of your vasoconstrictors, or there is an accelerated lysis of your endometrial clot, or there is increased production of substances that will promote vasodilatation. Your next category is secondary to iatrogenic causes. These often manifest with irregular bleeding or commonly as breakthrough bleeding. This may result from inconsistent use of either medicated or inert intrauterine devices or pharmacologic agents that would directly impact your endometrium, or agents that will interfere with your blood coagulation mechanism, or medications that will influence the systemic control of your ovulation. So what are these agents? Like if you have your improper intake of your pills, your IUDs, the intake of your steroids, the use of tranquilizers, digitalis, dilantin, rifampicin, griseofulvin, phenothiazers, or even PCA. And in the last category, it is now being categorized as not otherwise classified. In the FIGO system, it is not yet classified. In this FIGO system too, it is not otherwise classified. This refers to poorly defined and often inadequately examined patients. So this is most often attributed to either AV malformations, myometrial hypertrophy, or a cesarean section niche or defect. So how do we approach patients with AUB? We must remember that we should not treat unless the etiology or the evaluation is already underway, and we should always exclude pre-malignant or malignant lesions, especially if our patient is more than 40 years old. So, as always, we should ask for the history of our patient. We should always inquire into the character and the nature of her bleeding episode. We also ask for the related symptoms that may implicate a structural or histologic abnormality. We also ask if there is a family history of AUB or any intake of contraception, or if there are any presence of comorbid factors like high diabetes, hypertension, or gallbladder disease. So this is a structured menstrual questionnaire that we can ask our patient to help quantify the blood loss during menses. Women with menstrual blood loss tend to change their tampons at more than 3-hour intervals. They use less than 21 pads or less than 3 packs per cycle, and they don't have to change their pads at night. And if there is a passage of clots, it is often less than 1 cm that they are often anemic. If it is more than these categories, then you would label the patient as having abnormal uterine bleeding. If in your history, your patient will tell you that she has heavy menstrual bleeding since her menarche, or she has either one of the following: she has history of postpartum hemorrhage, or if she has surgical related bleeding or bleeding associated with dental work, or she has 2 or more of the following symptoms: she has bruising or epistaxis once or twice per month, for no apparent reason, such as frequent gum bleeding or a family history of bleeding symptoms, in 90% of cases, your AUB can now be attributed to a disorder of hemostasis. Then you do your physical exam after your history taking. This is done to identify any structural pathology or systemic disease as the possible etiology of your AUB. Then you do your laboratory test. The initial laboratory test is you always get your CBC with platelet count to determine if there is anemia. And then regardless of their sexual history, you should always rule out a pregnancy-related conditions. If you suspect that your patient has a disorder of hemostasis based on your history taking, then you get your prothrombin time, your partial thromboplastin time, your APTT, and your fibrinogen level. So if your patient has a von Willebrand's disease, then you request for a von Willebrand factor antigen, your ristocetin cofactor assay, and factor VIII to confirm your diagnosis. And if your patient has signs and symptoms of thyroid disease, then do a thyroid screening test. Your female hormone testing should not be routinely done in your patients. For your imaging procedures, ultrasound is the first diagnostic tool for identifying any structural abnormalities, and it is the transvaginal route is highly sensitive for detecting endometrial cancer in 96% of cases with the 5 mm cutoff of your endometrial thickness, and it also can identify any endometrial abnormality in 92% of cases. However, it should be done between day 4 to day 6 of your menstrual cycle to give you the correct picture of your endometrium. So your transvaginal ultrasound can show you the endometrial cavity structure. So it can identify the pathology that would contribute to your AUB. So it can also visualize your myometrial and endometrial features. So in other words, your transvaginal ultrasound can identify your PAM causes of AUB. So it can identify your polyps, either endometrial or endocervical, your adenomyosis, your leiomyoma, and your malignancy. The next imaging procedure that you can do is your SIS or your saline infusion sonography, but this should not be used as a first-line diagnostic tool. Your SIS can provide a more accurate evaluation of your uterus if you suspect of an intracavitary lesion. Hysteroscopy can also be used as a diagnostic tool when your ultrasound results are inconclusive, and in the presence of focal lesions of the endometrium, you can always use your hysteroscopy because this will allow direct visualization of your endometrial cavity, and you can always do targeted endometrial sampling of any suspicious areas in the endometrium. With your structured history taking, plus your appropriate and imaging lab testing, this will now determine the most likely etiology of your AUB. So once you know the etiology of your AUB, this will then guide you in your management strategies. So after knowing the etiology, you now determine if the AUB is either acute or chronic. When you say acute AUB, there is an excessive or prolonged bleeding more than 7 days of uterine origin in a woman of reproductive age who is not pregnant, and it must be of sufficient quantity to require immediate intervention to prevent further blood loss. So the bleeding in acute AUB ranges from modest to excessive heavy menstrual bleeding associated with hypovolemia, severe anemia, and even death. This is more common in anovulatory women, and when we say acute AUB, this often requires urgent or emergent medical intervention that often leads to frequent use of urgent care, emergency, and operating room resources. So the goal of treatment in acute AUB is to build up the endometrium with estrogen to provide initial hemostasis and progestins for endometrial stability. Chronic AUB, on the other hand, is bleeding from the uterine corpus that has been present for the last 6 months. So, in our management, these are the different factors that you should consider before managing your patient. So you should know the etiology, the severity of the bleeding, what are the associated symptoms and issues, what are the contraceptive needs and plans for future pregnancies of your patient, if there is any medical comorbidities like hypertension, diabetes, gallbladder disease, or if your patient is at risk for venous thromboembolic disease, or the preferences of your patient, either medical or surgical, short-term or long-term. The goals of therapy is the initial therapy will always include to control the bleeding, to treat the anemia if present, and to restore the quality of life of your patient. And then, after the initial therapy, the definitive treatment or the chronic medical therapy should be done. In acute AUB, medical management should always be considered before any surgical procedure unless the bleeding is due to a structural lesion such as a submucous myoma. So the goals here in acute AUB is to control the current episode of heavy bleeding, to reduce the menstrual blood loss in the subsequent cycle, and to restore the quality of life and address the primary etiology of AUB. So the first management for acute AUB is hormonal. You can give your high-dose conjugate equine estrogen at a dose of 25 milligrams IV every 4 hours to stop the bleeding. Or you can give your high-dose pills in tapered doses or your progestin, either oral or IF. For the non-hormonal treatment, you can give your tranexamic acid at 1 gram every 6 hours. So once your acute blood loss is being corrected and your anemia is treated, then you go for definitive treatment. If your AUB is secondary to a structural problem, either any of the pump, then you have to treat the structural problem. Then if your AUB is secondary to a coagulopathy, then refer to a hematologist for the treatment of that problem. If, if your AUB is secondary to ovulatory dysfunction or endometrial dysfunction, then you have to treat the endocrine problem present. If it is secondary to the iatrogenic causes or the not otherwise classified, then treat the factor or remove that medication. For maintenance or long-term treatment, if your patient wants to get pregnant, then you can only give your micronized progesterones or your oral progestin. If she desires contraception, then you can have a choice of Depo-DMPA, your progestin implants, your levonorgestrel intrauterine system, or your pills. For the medical management of chronic AUB, you still have a choice of hormonal and non-hormonal treatment. For the hormonal treatment, you have a choice of the use of levonorgestrel releasing intrauterine system or Mirena. Mirena is highly effective with additional benefit of relieving dysmenorrhea and reducing blood loss, and it can also reduce endometrial thickness and vascularity. The second is your Clara. This is the only pill whose indication is AUB. So it is a combination of estradiol valerate and your Dynogest. You can also give your cyclic progesterone, but at this time it should be given for 21 days to reduce blood loss. So your progesterone for 21 days will induce synchronous growth, development, and shedding of a structurally stable endometrium. And the micronized progesterone is much more effective compared with the oral form. You can also give your danazole and GnRH agonists in cases of failed medical treatment or when they are contraindicated. Non-hormonal also includes your tranexamic acid and your NSAIDs. In a study done by Mattison in 2013, wherein he compared the different drugs in terms of reduction of menstrual blood loss, it has been found out that the use of your Mirena has the greatest efficacy in reducing menstrual blood loss. This is then followed by progestins and your pills. The NSAID is less effective. And your POP or your progestin only pills and your etonogestrel implant is not effective for the treatment of your HMV. How do we manage AUB surgically? DNC. Dilatation and curettage is not recommended since it provides only a temporary reduction in bleeding. DNC is valuable only when it is done with hysteroscopy, especially when intrauterine pathology is suspected or a tissue sample is desired. The first-line diagnostic tool for AUB is our outpatient endometrial biopsy. So this is indicated for patients more than 40 years old if they have a risk factor for endometrial cancer and your patient had failure of medical treatment, or your patient is a breast cancer patient on tamoxifen who complain of AUB, or your patient has significant intermenstrual bleeding, or she has infrequent menses suggestive of an ovulatory cycle. So when AUB is persistent, unexplained, or inadequately treated, endometrial sampling is necessary, preferably by hysteroscopy, especially if you have these factors. She is more than 45 years old, she is obese, and has a genetic predisposition of your Lynch syndrome, and the endometrial thickness is more than 4 millimeters, or she has a cervical discharge of positive for chlamydia trachomatis. So these are the different risk factors for endometrial cancer. If your patient have long-term use of unopposed estrogen, she has a hereditary non-polypose colorectal cancer or Lynch syndrome, or estrogen-producing tumor, then you should do an endometrial biopsy. Or she is either obese, nulliparous, has polycystic ovarian syndrome, has history of infertility, on late menopause, has been using tamoxifen, or is diabetes, hypertensive, has gallbladder disease or thyroid disease, then you should do endometrial biopsy. You can also use endometrial ablation. This can be used as initial treatment in women not desirous of future pregnancies in the absence of a structural or histologic abnormality. You can also do your hysterectomy, but this should not be used as a first line of treatment. Hysterectomy is indicated in AUB only when there is failed medical treatment, it severely affects the quality of life of your patient, or your patient desires definitive treatment.